Yes, I think we should start. In the interest of time, we must start
Yes.
our next session. This is the Surgical Retina Symposium 4, The Rare and Horrible. So I would like to introduce our chairman and also first speaker, Professor Gianpaolo Guidi, and he will present on how would you approach post-operative endophthalmitis based in presentation and available resources. So please, Professor Guidi.
Thank you. So the question is the considerations that I have. How relevant is post-operative endophthalmitis today, especially considering that there has been an improved prophylaxis, there has been an increase in interventional procedures, and whether you're considering acute onset post-operative endophthalmitis associated with either cataract or intravitreal injections, or if you're looking at delayed endophthalmitis due to blebitis, buckles, or post-trauma, whatever, I think that in the course of your career, you will come across endophthalmitis sooner or later. So unfortunately, I see that even today, the approach is very conservative in many countries. I work in England, and many hospitals still have guidelines which date back from the Royal College, which does not advocate for immediate vitrectomy, as you would see is my approach. So I think it is important. It's important, and I will make the points that I think are relevant. So point number one, endophthalmitis is an abscess, a closed abscess. And you all have been through medical school, and you know that we drain an abscess. That is the definition. We don't leave an abscess in place. Point number two is that endophthalmitis should therefore be regarded as a surgical emergency rather than a medical one. So the approach obviously should be surgical, not only medical. Point number three, equally important, is endophthalmitis is a dynamic event. Many times this is forgotten because ophthalmology has a tendency to sit. I said sit on the problems and not deal with them in a timely fashion. Because nobody dies. If you have a heart attack, you go to A&E, and they have to act quickly because otherwise the patient will die. In ophthalmology, we don't have that problem, but the patient goes blind. So endophthalmitis has a tendency to progress, and I think that if we start defining it in a different way, therefore using the term early and advanced as opposed to moderate and severe, the concept of the evolution in time is more present. So I would think that we should be using the term early endophthalmitis instead of moderate, because we know that the early endophthalmitis will become advanced endophthalmitis if we do nothing about that. So what's the rationale for vitrectomy? And this is my point number 5. So removing the infective agent faster and more efficiently than can be achieved with any sort of drug. And also you will be removing the inflammatory component. We know that most of the damage is done by the toxins from the bacteria that are present in the eye, but also from the reactive component, which is built up by the body itself. So by removing everything, you are removing most of the damage that could affect the retina. Foregoing vitrectomy, on the other hand, will delay and limit visual rehabilitation. And it will require operations or reoperations more frequently. Now, this was shown even in the early vitrectomy study, which is what most people still use as a guideline, where it was seen that no eye which had undergone vitrectomy required a reoperation, whereas the eyes which had not undergone vitrectomy required an operation many, many more times. The EVS study was a bit misleading, I think, because it was done 20 years ago, but actually even more, 30 years ago. But actually, the fear of having a retinal detachment associated with vitrectomy is now, I think, to be forgotten. This was the main limitation really for the indications given in the EVS study, which said if you're removing the vitreous, remove the third, just about a third of the vitreous, which was obviously, if you're removing a third of the vitreous, you're removing the vitreous which is in front of the retina, not the vitreous which is sitting on the retina, and therefore you're not really dealing with the problem. But even in the EVS study, the results show that retinal detachment was 2.5 times higher in the non-vitrectomized group as opposed to the vitrectomized one, even in those days when the instruments were what they were. Today, we have made such advances in vitrectomy that we actually perform floterectomy, so why should we not be doing vitrectomy when this is really needed? So point number 6 is I think what the golden standard should be, a complete early vitrectomy, what we have called CEVE, and this should be the golden standard in treating post-interventional vitrectomy. So are there exceptions? Well, there are. If you have an uncertain diagnosis, TAS, very early presentation where the fundus is still visible, or you don't have the resources to do a vitrectomy. So TAS, I think, is easy to identify. Obviously, there is a difference in symptoms at which the patient refers. If you are uncertain, then I would suggest that you simply apply hourly topical steroids and close monitoring to the patient. Very early presentation, again, you can see the fundus, you're reluctant to go in, you're reluctant maybe to approach this case. The patient doesn't want the surgery. So again, you can use a tap and inject procedure, but close monitoring is also necessary. If you do not have close monitoring, you do not have the possibility to see the patient frequently, then you should not be using, I think, such a method. Yeah, and finally, the resources. If you do not have the resources and there is no fast track access to the OR, or you don't have sufficiently skilled staff, or there's no possibility of referring the patient to get surgery within a few hours, then obviously you don't have any other chance, no other opportunity, but to treat the patient with tap and inject, because time becomes the priority. So obviously you do what is best for the patient and you inject antibiotics. So point number 7, the role of intravitreal antibiotics. I would say that this is in limited use in cases which are detected early and where there is a clear contraindication, whether objective or subjective, to vitrectomy. And it is also can be seen as an intermediate step to limit the proliferation of the bacteria, which we know is exponential in time, while waiting for a vitrectomy to take place. A patient that has an endophthalmitis diagnosed in the morning can be very, very different in the afternoon. So if you have to wait in a hospital for the whole cataract list to finish before you get to endophthalmitis, then obviously you need to do something before that and you inject antibiotics. The technique is that to obtain a generous vitreous sample with a dry tap technique. This will allow you to get as much vitreous as you want out of the eye without having hypotony, because you will be substituting the vitreous which you remove with air. What the surgical technique is obviously to achieve the best possible view at all times. Occasionally you need to remove the corneal epithelium. Sometimes, exceptionally, you need to use a temporary keratoprosthesis. The first step is to remove the fibrin and debris from the anterior chamber. You may need to use mechanical pupil dilators. You start your vitrectomy by removing the anterior part of the vitreous, and you perform a wide posterior capsulotomy. You do not have to remove the IOL. And then you continue vitrectomy in a perpendicular fashion on the nasal side of the retina, so that if you're creating a tunnel which will reach the posterior part of the retina, if accidentally the retina is caught in your vitrectomy probe because it is detached, the damage will be minimal as opposed to being on the temporal side of the disc. Once you have identified the retina, you can move out in a tangential plane towards the periphery, and you try to reach as far as possible, ideally to the ciliary body so as to prevent hypotony, but if you cannot, or if you're in doubt, you stop. You only do what you feel safe you can do. Yeah, this is just a short video. This was a patient that had a TKP. This was many years ago. I think this came from a post-phaco when a stitch was not removed. So the cornea was removed and a TKP was used for the procedure. And you can see that there was quite we used pupil dilators, and then we moved into the vitreous and reached the posterior part of the vitreous and substituted the cornea, and the patient did quite well. This was an only eye patient, so he did quite well. We're quite happy. Do not attempt posterior hyaloid detachment because this can result in iatrogenic tears. If you want, generally it's sufficient just to reach the posterior pole. If you want to remove what we call the macular hypopion, so that layer of pus which is on the macula, then use the fenestration technique, which this is what I called it, and this is what I generally do. This is just a review of the steps I told you. Once you perform the posterior capsulotomy, you reach the posterior pole. Once you reach the posterior pole, then you can leave it like this, or you can go further and try to remove this pus which is sitting on the macula, and you can try to remove the posterior hyaloid so as to allow the antibiotics to bathe the macula and to bathe the retina. And you do that by simply creating a fenestration of the posterior hyaloid, as is shown here. You do not attempt a posterior hyaloid detachment because this can result in retinal tears. As you can see here, if you pull, you get a tear, so you stop. Okay. The use of antibiotics, I generally use antibiotics in the bottle after I've performed the vitreous tap, and this is more or less what is the standard, international standard today. Silicone oil, I would avoid the use of silicone oil routinely, and that's all I have to say. Thank you. I try to go as quickly as possible. Any questions? If not, we carry on, yeah?
Maybe we can have the Q&A at the end.
At the end, maybe,
yeah.
if we have time. Okay, thank you.
Thank you, Professor Gianpaolo Ghini. Warm applause once again. And our next speaker will be Dr. Tatiana Avanesova, and she will talk about scleropateria-associated retinal pathology. Please, Dr. Tatiana.
Thank you again for your kind invitation. Last time when I was in Lahore, I shared the case of scleropateria chorioretinitis. It's another case of this pathology. I just want to remind you that the scleropateria is the rupture of the choroid and neurosensory retina secondary to a high-velocity projectile adjacent to by not penetrating the globe. So it is not blunt trauma directly. And talking about macular hole, and my presentation is about macular hole associated with scleropateria. We just need to remember that we know the mechanism of idiopathic macular hole using OCT images. In traumatic macular holes, however, we have another situation. Our commonly held theory is that blunt trauma directly alters the anterior-posterior diameter of the globe in such a fashion as so induce stress on the retina as a significant areas of vitreous attachment. This is another type of formation of macular hole. I suppose we don't know exactly the mechanism, and sclerotinia has extensive damage, including rupture of the choroid, Brook membrane, RP, and retina adjacent to the projectile. Only high-velocity projectiles, such as bullet, passing to the globe, near the globe, could create the shock wave. And this shock wave forces is the main reason of rupture and other consequences. So let me introduce this clinical case. It's the male man, 40-year-old. He came with macular hole. The diameter is more than 1,000 nanometers, and he had his history of gunshot wound. It was 1 year before. The picture of the retina showed after this sclerotinia retinitis. You can see fibrovascular whitish tissue in subretinal space and huge macular hole. His visual acuity is 0.02 eccentrically. This is the surgery of this patient. After vitreous removing, I put the BSS bleb around the hole just to mobilize the retina because of this scar. This technique first was described by Canadian authors, Oliver and others. The same technique was described as hydraulic macular displacement by Ukrainian colleagues, Andrei Rubin and co-authors. And the same technique I used after the creation these blebs. I tried to remove ILM, mechanical movement with using scrapetano, air tamponade, and platelet rotated rich plasma was applied. Sometimes blood red cells enters into this drop. And you can see that the hole was closed, and this is the picture of this patient. We and he were happy because of this this result. His visual acuity now 0.15, and he told us that not only visual acuity but contrast sensitivity are also improved. And as a conclusion, I want to emphasize that sclerotinia may be a consequence of trauma by blunt object. In this our case, the patient developed the visual loss caused by full thickness macular hole, and the injury is believed to result indirectly from transmission of shock waves through the wall of the vitreous. And the surgery include vitreous surgery, intraretinal, subretinal BSS injection, mechanical maneuvers, ILM removal, biological glue application can help us this visual improvement. Thank you for your attention.
Thank you, Tatiana. Any questions? Shall we move on then and save the questions for last and comments for last? Okay, yes, thank you, Tatiana.
Our next speaker would be Professor Hussein Kakan from Lahore, and he will be talking about endophthalmitis outcomes and right treatment. So please, Professor Kakan.
Can I have my presentation, please? Thank you, Chair and Co-Chair. So I will be quick because it's late afternoon. So we'll talk about the endophthalmitis. Jim Paulo already explained a lot of things. So the endophthalmitis, usually what we get is very late presented, and I will talk about the postoperative endophthalmitis in these cases. So you can see what type of endophthalmitis we get. Here is the eye of a patient. He presented us with the pass in the anterior chamber. It's over there. So first I'm just removing the hypopyon from the anterior chamber, and this is pseudophakic eye postoperative, got the endophthalmitis. So first you get clear the anterior chamber, and then you get inside. The only difficulty in the beginning is that you don't have a clear view. So just have the patience and focus on the posterior pole. So as much you can do it in the core vitrectomy and then go peripheral. Don't be heroic to pull the PVD and do the PVD. Here you can see the lot of exudate lying over the retina, and use the low vacuum high cut rate in these cases, because the high vacuum may get a tear and detachment of the retina. So with the slow and with the patience, you can do the vitrectomy at the posterior pole and then the peripheral retina. Usually I don't prefer to remove the debris over the retina to not to make to slough the retina to pull it over away. So I try to remove as much vitreous as it is possible, but not the harming the retina. I sometimes wait for a few seconds just to churn the BSS fluid inside the vitreous cavity to get rid of these debris from the retina. So at the end of the surgery, you can see the macula is clear. There's a little bit retinal ischemia and oozing of the blood from the disc vessels. So, it's not about the core vitrectomy. You have to proceed for the complete vitrectomy when it is a pseudophakic eye, but just don't harm the retina. And this is the eye, as Giampaolo mentioned. So this is the eye with the oiled eye. Close all the eyes with the silicone oil in endophthalmitis. So it's my preference from last many years, and I do the 360 and circling laser in all these patients. This is one more case. So here you can see how much the difficult job is for the surgeon. So you can see the anterior chamber is full of the hypopyon and the corneal edema. So the main thing is the difficult job is only when the cornea is not clear for the Weiss surgeon. Vitrectomy is not difficult, but you don't get the clear cornea. The same situation, remove the hypopyon from the anterior chamber and you see only the optic disc is visible. This is also the pseudophakic eye, but I moved inside the vitreous cavity very slowly. Just be focused in the center of the eye. Don't move peripheral unless you find a major vascular arcade or the optic disc. When you find the optic disc, then try to move on the peripheral retina rather than moving on the peripheral retina appears. So you may get iatrogenic break, and if you get iatrogenic break and gets the bleeding with all the pus inside the vitreous cavity makes the job very difficult, and it's very difficult to control. So here you see now I have cleared the posterior pole. Now I am moving the peripheral because I know the location of the retina, and the retina is attached, and you can do easily even the vitreous base shape, because these are post-operative eye with pseudophakic eyes. So don't leave much vitreous, because if you even put the oil, after putting the oil, when you will remove, if there was a lot of vitreous, these retina will get detached, because these retinas are very fragile after the inflammation and after the infection, and these retina has a high incidence of PVR. So be careful for harming these retina per-operatively. Just respect and do complete vitrectomy and circling laser and put the silicone oil. In the question session, I will explain why I am talking a lot about putting the silicone oil. You can see the worse than worse. So first three, and here it is more degraded. Even there is iris prolapse in the paraoperative pseudophakic eye, and lot of pus in the anterior chamber. The similar way I am going with the Simcoe cannula. So the best thing for the retinal surgeon is if you find a clear cornea. For example, this patient has a much better clear cornea. So the job was very easy for me. Just get the debris in the vitreous cavity in the middle and do the core. And once you find the optic disc and major vascular arcades, just go to the periphery. The same principle is for every. Don't think it's a thankless type of vitrectomy. When you are in a hurry and you lose your patience, just keep your patience alive in the endophthalmitis vitrectomy. But don't treat it like it's a blind eye and you are not going to make it more blinder. You should have a much more patience than any other retinal surgery in endophthalmitis, because your patience is going to give some results. But you're understanding that this is a gone eye and I have to give something wrong with it, or you can be in hurry, so it may end up in very bad eye. So just the patience can end up with very beautiful eye. So here you can see the retina is clear. Oil, I am injecting the oil, and with the eye that have presented the pre-operative image you have seen, and look at the post-operative images. So you can get, but don't take it as a 15 minutes vitrectomy, don't take it as a core vitrectomy, take it as a most difficult vitrectomy in retinal surgeon, because you are dealing with the complication of somebody else, or you are dealing with your own cataract surgery complication. So deal it like more heroic job than a basic vitrectomy. And nowadays, I don't believe on these core vitrectomy words, and there is nothing like a core vitrectomy no more in the endophthalmitis. We are not talking about the 1992 or 93. We are talking about 2023. There is nothing we are talking. So you see, eyes full of pus, even the membrane, and it's flushing out all the pus from the interior chamber. So I am just getting rid from the debris from the posterior capsule over here. So there is very bad view. What I do, I just get on the basic principle of retinal surgery. Your light should be focused on the tip of the cutter. Don't lose this. Your light should follow the tip of the cutter as the ballerina. In ballet dance, the light follows the ballerina. So it should be like this. If you will not do this, you will harm the retina, you will make the tears, and it will start bleeding, and nothing will happen here. So nothing much special. So it's the same procedure. So now you see almost all the vitrectomies that I'm showing for the endophthalmitis, I am even shaving the vitreous base also. So you can see it's not difficult, just the patience and a little bit more clear view. The only thing is, if the retinal surgeon gets the clear cornea, it makes our job very easy. And that's the only point that I am here. And hopefully you will like I have plenty of endophthalmitis videos. I don't know why I collected this one from where. You can see it like this. So if you will like, you can see. So what worse you can find than this? Who will going to operate it? So everybody will think, just get rid of this eye, somebody else will operate. No, but you have to do it. So the basic principle is similar. So you get inside, and I have a lot of videos, so I will not show all of them. Thank you so much for your attention. If you will have any question, I am here. Thank you everyone for being at the Lahore, and have a great evening.
Dr. Hussain, thank you for presentation. Question, always we put silicone oil?
Yes, in all the post-operative endophthalmitis, I always put the silicone oil.
What?
Why? It is bactericidal. And second thing is, you don't have a bacterial growth. Third thing is that retina is fragile. And when the retina is fragile, these have so many micropunctures. So many micropuncture, when you leave it at the BSS, later on fluid churns over the retina. And these micropunctures open like a retinal break. And that's why I put the oil. I don't keep it for 6 months or 5 months, just 2 or 3 months, 1000 centi-stroke. So I get two benefits. I get very clear view through the oil of the retina. Even I can enhance the laser.
So the second question, so laser is important to do?
Sorry?
Laser.
Laser is very important to do in my sense. Yeah. I believe that it should be done, because when you will remove the oil, there will be a second cascade of inflammation. Oil, once give the inflammation, when you will remove, the surgical trauma will give the inflammation, both will enhance the PVR. So if you have a peripheral laser, circulating laser, it most of the time prevents anterior break retinal detachment in these cases. So I believe there is no harm in doing a circulating laser, even you don't find any breaks. It will benefit at the end, yes.
Professor Hussain, what do you do with the IOLs? Do you remove them, leave them? How do you manage that?
Believe me, I mean, if I go 7-8 years ago, I tried to remove these oils with the bag. But now I know how to get rid of the bag infection. Most of the eyes, when you do the complete vitrectomy and you put the oil, I usually do the posterior capsulotomy and wash all this capsule with the cutter and churn the fluid inside it. I just do the posterior capsulotomy to get rid of the posterior capsular opacification, and if it is there, and I switch the infusion with the antibiotics. So nowadays, from last, you say 7, 8 years, I have not removed the bag, never. Because removing the bag, what ends up? These are inflamed eye, remove the bag, cornea goes away, then the oil doesn't stay in, oils comes interior chamber, and they have already inflamed, they have already inflammatory glaucoma over the oil, over the pupil, over the interior chamber, ends up in a pale optic disc. You have done the surgery, patient got blind. So I don't like this one.
Can I just confirm that if you read the first work that we published with Ferenc Kuhn, Professor Kuhn, this was back in 2006. It was the first, I think, challenge to EVS when we came out with these steps which we are mentioning. And we never removed the bag because, as Professor Kakan is saying, you don't need to, as long as if you create a unicameral eye. So you have the free flow of antibiotics from the back of the eye to the front of the eye and vice versa. Then you don't need. There are a few issues that could be discussed here. One is if you use antibiotics, saying, do you use antibiotics in the bottle or do you put them at the end?
No, I use it in the infusion line.
Same here.
Same.
Now that is unusual because generally they would be recommending putting that, but it doesn't make sense because if you want to reach all the points of the eye, then you put them in the infusion bottle and you're sure where your vitrectomy probe goes, your infusion goes, and your antibiotic goes.
Yes.
Now, the only thing I would discuss, this is a point of discussion, I don't think there's an answer, is whether to use silicone oil. I think every eye is different. So I have done some very complex procedures where it was milky white, couldn't see anything. That's why I said, if you don't have any visibility, then you go down, you create a tunnel. You don't spatulate because if you find the retina is detached, you can hit the retina. But some eyes don't need the silicone oil. So to me, the silicone oil is necessary if, one, if you think you've made a break, two, if you've not done a complete vitrectomy, so you know that the following day you're going to have a lot of debris and you cannot see the fundus. If you put the silicone oil in, then you can see the fundus.
Yeah.
That is very important because if you've done a vitrectomy for endophthalmitis, you can't see the fundus, then you panic the following day.
Yeah.
Is everything
I
okay?
totally agree. I totally agree.
So silicone oil is very useful. But is it always necessary? I don't know. So certain cases where you're certain that you've done everything correctly, you haven't created any problems, then maybe I would not be using the silicone oil. Another thing is the laser. Sometimes you cannot reach far enough to the periphery to do the laser because you, as you rightly pointed out, and as I said as well, you go as far as you feel comfortable. It's better to leave something behind than to create damage.
Yeah, iatrogenic.
So sometimes you cannot do the laser periphery
Sure.
because you don't see what you're doing.
Yeah.
But
So
there's so many points that can be discussed.
So I agree. So the endophthalmitis that I get yesterday and I operating today, less than 24 hour or 48 hour, I wouldn't put anything. I wouldn't put oil, nothing you get. But the endophthalmitis that I've shown, there are more than 15 days, 20 days. We usually don't get early endophthalmitis. If I get in some patient and I have the opportunity to operate the same day, I will never put, and I will leave on BSS. But the endophthalmitis with these conditions, I cannot leave on BSS. I am very much curious about the retinal detachment in these eyes because these retinal detachment doesn't come in the control. Thank you so much. I am taking too much time. Thank you so much for having me here. Thank you.
Thank you, Prof. Kakan. I think we must proceed to our next speaker, which is Dr. Raza Alisha. He will talk about surgical outcome of post-intravitreal bevacizumab or Avastin endophthalmitis outbreak. Please, Dr. Raza Alisha.
Okay, today I am going to present a surgical outbreak of 68 cases of 78 eyes which occurred here in province of Punjab in the month of September. And that was a very horrible scenario and situation, and it created a lot of problem for we consultants and we are surgeons, that that one of the vendors, he was responsible for all that stuff. And what happened that this though we know that this is a poor country, rather in which we give lot of Avastin, and though the counterpart of it is Eylea or Petizra, but the patient's non-affordability doesn't let the patient buy such costly things. So there were two ways by which we used to get this Avastin. One was directly we got it from one of the recognized hospitals such as Shaukat Khanum, and the patient used to bring that himself. The second was that through this vendor, he used to bring at the place where the surgery was to be done, and he was providing this Avastin for many years, 4 years, and there wasn't any complication. The advantage of that was that this was being available at the doorstep, and without any problem this was happening. But due to poor dispensation, and due to there was a government inquiry which took place, and which showed that due to poor dispensation and sterilization and lack of cold storage, this all these cases happened. And this was not happened this didn't took place in one operation theater, rather it was in the whole of the province, and it was 13 cities in the province of Punjab, and there were multi-centered operation theaters where they were injected, and the patient came the next day. Some were reported they with a fulminant endophthalmitis, and when there was a this organism was this was stab was done, it was Pseudomonas aeruginosa, and it was very difficult for us to do vitrectomy at that stage. And I'm just going to show you some of it. Next, please. Now, what you see, the patient presented with either they were, most of them were NPL when they came to us. And unfortunately, 7 of the cases have been injected bilateral injection Avastin. So they were bilateral blind. And there was a hue and cry amongst the, in the media and all over, that this, what has happened. So what resulted in that it caused lot of problem amongst the ophthalmologist and here. And we know that this, next please. We know the risk factors for post-injection Avastin. It could be drug-related, it could be injection-related, or it could be patient-related intrinsic factors. There are different types of role of biosafety labs which are available. They are biosafety levels 1, 2, 3, 4, where the 4 is the highest maximum level of containment, and the organism obviously was Pseudomonas. And what you see here is that when the patient came, most of them were having severe endophthalmitis, and they were having preseptal cellulitis, they were having severe pain and redness, and some of them were having even perforation of the cornea as well, two of them. And it was in different, there was a center which was made at one of the teaching hospitals, that was Mayo Hospital, where all the cases were referred, and there was a center where all the patient came, and we actually did all what we could. We could do, we did vitrectomies in them, but it was not possible for us to do proper vitrectomies. We were not able to do full PVD. But only in some cases there was a limited fenestration of posterior hyaloid was done, but in mostly we were not able to complete the vitrectomies. And ultimately the patients actually came a few of them, it was on the 19th of September that this injection was given, and on 20th of September, one of the patients reported, whereas, what are you doing? Whereas 7 of them came on the second, third day, and later on 25 of the total patients came, and out of them 4 didn't, they refused admission in them. And this was what we did. We did this vitrectomy. Obviously, that was the first choice, but because the patient came late and they presented late, so we all obviously started with this empirical therapy, and then targeted therapy was also given, in which we did give the fortified meropenem, and also we give IV meropenem in them. And one of them two of them had this corneal perforation. We went for tectonic graft, and then we had to put conjunctival graft over it. Now, this has already been that mostly the patients came with no projection of light, and they were 60% at the time of presentation, whereas there were 30% were those who presented with projection of light, and the rest of a chunk had counting finger 1 feet and counting finger 2 feet. And when visual acuity at discharge was that mostly they were 97% they were blind totally, and only we could save only 2 eyes. The pain, a few of them presented with no pain, but some of them presented with mild pain, moderate, and then severe pain at presentation. And during this whole procedure and whole this time, we were able to get their pain. They didn't get this, and it was resolved. But the role of meropenem was that when we were giving meropenem, though it was reducing, this was after vitrectomies, it was the infection already has settled, but this resulted in this epithelial defect in some of the cases. The reason was that too much of this was being given. And similarly, AC lavage and this all were done. Now, what is the take-home message? Take-home message is that we all across the province have selflessly, with dedication, commitment, and professionalism, have treated these patients in order to prevent whatever disastrous effect that could have resulted in it. Mostly, they were going into orbital cellulitis as well, and they were having a very difficult time in getting their proper blood pressures and all that stuff in a normal place. And as it has been proven that the injection Avastin outbreak refused resulted in poor dispensation and sterilization by a vendor. Therefore, government had taken this concrete steps that it has stopped this Avastin injection. But what this concrete step will result in, that now they have halted all this Avastin, so the poor patients won't be getting this Avastin. We will be giving them Petizra or Eylea, and this will be not fair for the patients due to this one vendor fault. And we hope that this OSP and other the PMA will help us out in getting this again started, this Avastin again. Thank you very much.
Dr. Raza, congratulations. 3 points and 1 question. Your Minister of Health last night pointed out about this epidemic. So they all came from the same batch, correct?
Yeah. They all came from the same batch. They were all these were injected on 19th of September.
So, okay, so 3 points. 1, it's not just the so-called poor countries, but also the so-called rich countries, which are not rich anymore,
Yeah.
and they all use Avastin.
Yes.
So we're all switching to Avastin
Yes.
now. So,
So
this
this is
the-
quite true because we are
Yes.
using. I've been there all, and we are injecting this Avastin
Yeah.
all over the world.
Yes.
And the thing was that this person, what he did was that he took this 4 ml of this Roche Avastin, and he made 80 injections out of them.
Yeah.
And these were either not properly handled, or the cold storage was not maintained properly, or what has happened.
Well,
That is-
you need a centralized pharmacy which has laminar flow,
Yeah.
so that that you're getting the product
We
which
can
is
pull- yes. Yes.
So that's the first point. The second point, which I really want to make, and I tell my colleagues in the UK and in Italy as well, do not inject bilaterally.
Yeah, don't
Because
let-
here you have a case which is
Yes.
really
Yes.
desperation. I mean,
Yes.
it's a tragedy. I know that it saves money, it saves time. Patients may be happy to have that because they don't have to come back, but it is very, very risky. If you get a really aggressive pathogen, then the eyes may be lost, and if you lose 2 eyes, it's a
Yes.
real problem.
And secondly, that if the endophthalmitis, which occurs with either Avastin, Petisra, or Eylea, that endophthalmitis to control is very difficult. To control endophthalmitis due to cataract or trabeculectomy, that is something different. We have some time, but here we don't have any time. So the lack of time, lack of resources, and all this resulted in late presentation of patients, and so we couldn't help them.
Thirdly, congratulations on being so aggressive and being so efficient and doing what you could. The final question, does anybody have experience with using iodine povidone in these patients? Because if you have these really aggressive germs,
Yeah.
antibiotics are slow to act, whereas something like a disinfectant, such as iodine povidone,
That
actually
is-
works quite well. So have you ever tried that?
Yeah,
I
we
had
do
2 cases
try.
which I
Yeah,
treated.
yeah, we do. That is the protocol here that we give this
No,
pyridine.
no, inside the eye.
Inside, no.
No, inside the eye, instead of using antibiotics. No,
No, per
no.
option.
In these cases, endophthalmitis, instead of using antibiotic, you use, which takes some time to act, you use iodine povidone, which acts immediately because it sterilizes the inside of the eye.
Okay. Okay.
Yes.
Yes,
Intravitreal.
yes. You perform the vitrectomy and then you add at the end
Intra-ocular.
a concentration of 0.25% iodine povidone. There is in the literature, you can find it. It's been published, and it works obviously immediately. It kills everything. And here, with such damage to the eye, I don't think you could do anything worse. So
Yes.
maybe it was worth doing that. I think this has raised a lot of interest. Can we take a couple of questions, maybe? Yes.
Thank you. Guillermo Salcedo from Mexico. A great presentation. I congratulate you for getting all the data together. And I have a question and a very brief follow-up comment. So the question is, when you are injecting Avastin, do you take it directly from the vial, or do you have like a compounding pharmacy?
This was that it was already prepared.
Right.
One, we didn't prepare it ourselves. That thing was 0.05 Avastin. He brought in the syringe and with a cold ice pack in it, and he distributed all over.
Right.
So it was not us who actually made it. This is first point. And it was not I who have given it. It was 68 surgeons who gave it all over the province of Punjab.
Okay. So the follow-up comment is because in Mexico we also had an outbreak of in just one hospital of 17 cases of endophthalmitis after an Avastin injection. And our conclusions after analyzing the microbiological cultures were that the organisms were probably due to pretty much a contamination and counterfeit of the vial. And this, in turn, we concluded also that there's a lot of piracy of Avastin, particularly in Mexico at least, because it's a very, very common drug. So a lot of people might be taking the vials and the boxes and everything and just be filling them with pretty much tap water, which is terrible. And that's like one of the most probable causes to have an outbreak. It was counterfeited. I don't think that if you had if there was a problem with, for example, the compounding pharmacy and a difficulty on preparing the doses, the possibility of having all of those patients from one batch is, I think, it would be very low. So again,
Yeah,
thank
it
you.
was
and
basically the fault of a vendor who actually distributed. I don't know what he did. That all the cases in which there was a culture swab was done, it was Pseudomonas aeruginosa.
yes.
So, and it was because we all the surgeons, they were proper trained ophthalmologists. All they were retinal surgeons who gave it.
I think it's a political problem here. It's the governments should
Yes.
say, Roche, you want to sell your
Yeah.
products? Fine. Then you provide us with the product. We have compounding
Yes.
pharmacies which are state controlled. We know the quality of the things coming out. This will avoid all this piracy. But obviously the pharmaceutical companies have an interest in not doing that. So it should be the governments that move in that direction. We can only take one more question and then we have to move on.
Thank you very much. I have a few questions, and first of all, I would like to extend my deep gratitude to Professor Dr. Razali Shah Sahab. He is Professor of Ophthalmology at Institute of Ophthalmology, King Edward Medical University, one of the renowned institutions across the Southeast Asia. He had already decided to go for a visit, for his family visit for abroad before this outbreak. But immediately, whenever this disaster, after this disaster, he cancelled his visit and he stayed here, and he did his best to provide as much as possible rehabilitation what could have done for the patients. So big round of applause for him.
Thank you. But
And
that was my.
I would like to ask one question. At what concentration you use povidone iodine in these infected patients? That we would certainly like to know.
Not 0.25%. Not 0.25.
Zero in infusion, or in infusion you use
At
it
the end of the procedure, yeah, you inject 0.25%, 2 cc's.
in the vitreous.
In what? Well, not the vitreous, in the vitreous cavity, yeah.
Okay.
Because the vitreous is gone.
And another question: what is
And
your
do you put it always routinely? Do
No,
it
no,
or-
no, no. This was just so. If you look in the literature, you will find a few cases have been done and found to work efficiently with no toxic effects. I decided, I always had this in my mind because I used povidone for many other things for when we had viral infections of the cornea. So it was something in my mind. I never had the courage to do it myself. With the literature in my hand, then I said, well, I'll try it. And I did in 2 very advanced cases, like Professor Kakan was showing. So people that had come late, they were, incidentally, they were post-IVT as well. They had come very late. They had come on a weekend, so the person on call, the junior on call, simply injected and nothing else. It did not work. So the situation was dire. It was very advanced. At that point, it seemed that antibiotics alone would take too long to act, and there was nothing to be lost because the eye was so damaged already. And so I tried. And I can tell you that it did clear up the eye much faster than normal antibiotics would have done. So this is just, extreme cases. But the cases which were shown here were extreme because, as you rightly pointed out, they came late.
yes,
Okay?
yes.
Or
you-
maybe even if they come early, the pathogen was very aggressive. We
So
don't
in
know.
in
Yeah.
our part of the world, we can never imagine to close these vitrectomies without silicone oil. We always have to go for silicone oil injection in our part of the world, in case while dealing with the vitrectomy in cases of endophthalmitis because of late presentation.
Your question is if to use silicone oil or not?
No. We always have to use silicone oil as a tamponading agent and barrier lasers while dealing with the vitrectomy in cases of endophthalmitis.
I don't think that's absolutely necessary.
Yes.
It depends, again, from what condition you find. It depends from many things. One, it depends from what case you are dealing with, just how advanced it is. So if you can't reach much of the periphery, how are you going to do the laser? It's impossible if you leave enough pus inside the eye because you're afraid to move forward. It depends from what you have done. If you feel that just how well you can see the back of the eye, if you feel that you've made some tears in the retina, it depends from many things. It depends if you leave enough pus inside the eye, enough material inside the eye, then you're not going to be seeing much the following day because it becomes cloudy. So that's when you want the silicone oil, not because silicone oil does not have any function against the bacteria. It is not bacteriostatic. It simply, bacteria will grow inside the silicone oil, but they will grow in that interspace, which is between the silicone oil bubble and the retina.
Yes.
Okay, so there's no antiseptic function of the silicone oil. It's just to keep the retina flat. If you've made, like any other procedure, if you have reasons to suspect that the retina will detach because you've done something you shouldn't have done, or because something has happened, or whatever. The other reason you may want silicone oil is because if you leave enough material behind, and the case was very complex from the beginning, like yours, then you're not going to have a view the following day because everything is going to be cloudy. And that is not good. So you put the silicone oil because then you can see the back of the eye and you can see what's happening. Those are the only reasons. But if you have a post-op endophthalmitis, which is recent, 2-3 days, whatever, and fairly, let's say, not advanced or moderate, why put the silicone oil? You don't need to.
One more question. Do you have any specific or your preference protocol for inducing PVD in these fragile or necrotic retinas related with the endophthalmitis?
Yes, as I showed you before, you don't induce PVD. Inducing PVD is silly. You don't have to. You can be happy just having removed most of the vitreous and leave the eye as it is. Leave it. Then if you have in the following months, if you have a macular pucker or whatever, you can go back. If you really want to be extremely detailed and go and try to get that antibiotic directly on the surface of the retina, then you do, as you showed, I think, you do fenestration. Okay, so hyaloid fenestration. You simply the hyaloid, like a book. You don't go past the vascular arcades, correct?
Yes.
Do you agree?
Yes.
Yeah. That's what you do.
So the last comment, do you have in your local perspective a centralized pharmacy that is
Yes.
dealing with these prepare injection and the
Yes.
injections are given at the same place? Are there any transportation system maintaining the cold chain? Is there any, would you like to comment?
So there is a centralized pharmacy for our trust, which is the whole, it's a county, Sussex County, so that we have a main pharmacy which supplies all the different, and yes, we have a cold chain but the contents of the obviously is sterile, but the syringe is not. So that is something which we have been trying to work on, but still have not gotten anywhere. So if you are not handling the syringe properly, you can get endophthalmitis. But the content is obviously obtained from Roche, and then the compounding pharmacy, which is a centralized hospital pharmacy, will give the product with a cold chain. But even then, you can get endophthalmitis with Eylea, with Lucentis, with anything.
The same procedure that with the Eylea and Patizra is adopted should be adopted with the Avastin, so that we don't have this problem. Otherwise, injecting Avastin now for us is something which is very difficult. Probably won't give it.
So thank you very much for all your kind attention.
Thank you.
Thank you
very much.
Shall we move on?
Yes, I think we're about to run out of time, so we still have a couple of speakers. And next I would call Dr. Nicholas Lobari from Georgia. He will talk about surgical embolectomy for retinal artery occlusion. Podium is yours.
Thank you, dear Chairman, and thanks to Professor Hassan for giving me opportunity to come in this wonderful conference and share some cases this topic is a little bit different to compare the topics discussed in this session, but those are quite rare. So we all know what's arterial occlusions, central or branch arterial occlusions. Mostly they can be acute or chronic, and in about 1/3 of cases, 30% of cases, we have remaining chorioretinal artery actually, which preserves the function of the central macula. So the diagnostic methods, we have numerous, so in all of them are very important, but among them, only two, which the fluorescent angiography and OCT is very informative. So the chemical consistency of the emboli are different. So it can be calcific emboli, mostly we see cholesterol or calcific emboli, and then comes a fibrin emboli. So, but we have many others as well as enumerated here. So there are different clinical cases. So the acute cherry spot, we know why it appears, because around the macula is whitened, and this pallor is induced by the swelling. Another acute CRAO, we have another type. So when the middle layer of the nervous sensory retinal vasculature is affected, we call it PAN. If it's deep, then AMN. Here is a combination of the CRVO with the branch artery occlusion, how it looks on the angiography, and so on and so on. So I'll skip some videos as well, so I'll be very short. In about 20 to 40% of cases, the emboli by itself is visible via fundoscopy. So, the treatment itself, the traditional treatment, of course, it is focused to induce the lysis of the tromb or the emboli to make this emboli to travel farther the branches, which allows the rest of the retina to recirculate and also to improve the oxygenation. But of course, this traditional treatment is not always enough to restore the vision and visual function. This is the animated movie. So we should know that it's a stroke of the retina, like we get stroke of the brain, and it's a systemic disease. So if it's a cholesterol emboli, mostly it comes from the internal arteries, and if it is the calcified, it comes from the leaflets of the heart. So this is a clinical cases, just few clinical cases you see. Which one is it? Okay, you see the emboli over there. So this is how it looks like on the autofluorescence. So the cholesterol emboli, it does not autofluoresce, it doesn't cause the fluorescence too much. This side-by-side color photo with the autofluorescence, and this is very important now. It's a very early fluorescent angiography, and you may see that the filling on the early arterial phase of the inferior and superior branch, it doesn't happen at the same time, simultaneously. So the good thing about the arterial occlusions is that in most of the cases we get arterial occlusions, but they are not completely occluded. So this allows us to even after several days or several hours to operate and get some improvements. So not only chronicity, but also the amount of the closure of the lumen is very important to be considered to plan the surgical treatment. So here it's a 41 gauge cannula usually, which I use to dissect the retinal artery. So I will skip this and I will show in other videos because I have this many. So this is when we surgically removed this emboli here. It was a cholesterol emboli, and you see on the autofluorescence there is no more fluorescence in this frame. So this is the early arterial phase, and you can see that the filling of the superior and inferior branches are happening simultaneously, and this is the early venous phase, the mid phase, and late phases. And here we have another case, and of course this patient had a good central visual acuity, but the paracentral scotoma, which was corresponding to this retinal lesion. This is the autofluorescence. So we have the hyperfluorescence here on the autofluorescence frame, and it means more or less we can assume that it's a calcific emboli. This is what happens in early arterial phase, and the filling of the inferior and superior branches are not happening same time. Of course, the superior branch comes with delay, and this is what happens in middle and late frames. So this is the surgery, the same technique we apply here. So what we need for this surgery to perform is the high magnification lenses and the special instrumentation to dissect the retinal artery. Actually, retinal artery is not that fragile. It's very elastic and it's very hard to get through. So this contact lens, in my opinion, I have tried many different contact lenses for the high magnification, but the AVI macular window is the best to maintain the stereopsis. So this is a 41 gauge cannula, which has even as a sharpened tip. So with this tip, actually you can find this emboli, and over the emboli just cut the wall, anterior wall of the arterial branch. So you will see now that the flow which comes out, so when the hemorrhage appears, it's a good sign, and you will see it. I'm manipulating with the tip of this instrument, and the emboli will come out from the arterial lumen completely. It's just about, yeah, now it's out. You can see that. So it's quite bright, and now I keep the high intraocular pressure about 60 to 70, which induces partial closure of the central retinal artery. Now I go down. I want just more pulsation and more flow to take out if any other small size emboli are maintained just in a deeper lumen, and using the aspiration with a flute or whatever instrumentation. So we remove this from the vitreous cavity. So this post-op photo, you see we manipulated the optic nerve, and of course we are getting the partial optic nerve head atrophy, the pallor. And this is there is no more hyperfluorescence on the autofluorescence frames, and this is very important photo which shows the simultaneous early arterial phase, simultaneous filling of the inferior and the superior. So there is no more delay, and patients usually they get improvement of the vision and the scotoma right to the next day. So you see the early venous phase and the high magnification, even the foveal avascular zone was reformed, and you can see the recirculation on the superior branches. Actually, this patient got quite a good visual acuity after this treatment, and this is another case. So not all the cases are good candidates for the surgery, because you can see early arterial phase, only nasal superior branches it has the circulation, the rest is closed right here. So it has a total ischemia, and and this patient came after 3 weeks. The second case actually we treated after 1 week. So here you see it's hardly we get any filling of the retinal arteries and following the vein phase. This is after the surgery here, and you can see the early arterial phase of the same patient. Actually, the recirculation we got, but the visual function was not restored, unfortunately, because of the chronicity and because of the amount of the closure of the lumen of the central retinal artery. So it's a late phase over here. So this is another video here. So this video shows that it's not necessary always to see the emboli itself. Sometimes you are having some remnant tissue. It's a crossing of the when you have the first bifurcation of the central retinal artery, and if there is a tissue, probably it's a glial tissue or some remnants of the tunica vasculosa lentis. Then what I do under the high magnification, I try to detach this tissue from the vessels. So I relieve the compression, and you can see even the erythrocytes and the small particles of the cholesterol emboli are moving on the periphery, and it's the same patient as I have shown you with the excessive ischemia, and now we have the restoration of the circulation, and you have seen already the fluorescent angiographies after the surgery. So we should, when we are dealing with this kind of pathology, we have been taught that 90 minutes is enough to cause irreversible damage of the neurosensory retina, but this is happening in case when we have the complete occlusion of the central retinal artery or the branch retinal artery. In those cases, in clinical cases, we rarely see the complete occlusions like I have shown as the last case, and we have to, apart of these traditional treatments which we already discussed, we have to always give a try and remove the emboli or do, and even there is another authors who suggest it's a massage of the central retinal artery, and they have got quite a good results. Thank you so much for your attention.
Thank you, Dr. Nicol. Excellent results. But yes, maybe we could save questions for later. I must continue with our next speaker. Yes, is Dr. Faisal here? Yes, so Dr. Faisal Iqbal, he will talk about endophthalmitis vitrectomy difficult cases.
Can you start the... Thank you very much, Chair, for the... Okay, we have discussed most of the basics previously, as Dr. Guinea has already explained. Why are we basing on endophthalmitis vitrectomy study while we are in 2023? Much better surgical outcomes are to be predicted. And now let's go directly to the videos. So the thing is that we have to get a very good clear cornea and good view. In this particular case, we are removing the membranes on the lens, and after removing all these debris and trying to displace it with a little bit of OVD, but still there are few fibrinous membranes which are to be literally cut off with the help of a vitreous cutter. This particular case presented 20 days after the surgery and was injected twice with an intravitreal VFD, but was not responding in any way. In this particular step, we are opening up the posterior capsule, getting hold of the posterior capsule and bag, and the vitreous is all filled up with the fibrinous exudates and pus. Now, this is what we see at the first step. We are removing the vitreous as much as we can along with the pus, and very difficult in identification of the retina. While going on the nasal side of the retina, we will first identify the disc, and later on we'll try to remove as much of the vitreous as we can. In this particular thing, PVD induction, as it is already a little bit difficult, different, but there was already some inferior retinal detachment, and we are trying to remove as much of the membranes as we can. So these membranes were literally detached with the retina because of all the infusion flow. So this is the kind of things we encounter when we delay the vitrectomy. Patients are usually very reluctant, and as Dr. Guinea already said, we try to sit on it and try to get most of the complications. So it is pus and blood filled vitreous totally removed. So after air fluid exchange, went with the silicone oil, and this was one small iatrogenic break that happened during the whole surgery. We're going to lase it after putting in the silicone oil. So this is another case in which there is very difficult identification of the retina, but again opening up the posterior capsule and washing away the debris with the infusion. I always put vancomycin in the infusion, or whichever the antibiotic is available, usually in the infusion, not afterwards. Okay. Again, there are a lot of exudates and pus encountered, difficult identification of the disc, and when we removed the posterior vitreous, it was all covered with the blood. So here the colonies and the blood is going to get flushed with the back flush. See, but the retina is all attached. In this particular case, the vitreous base was too much involved, and the bag, the periphery of the bag was totally fibrosed and filled with the pus. The bag was not getting any clearer. So in this particular case, we opted for IOL removal. So IOL was cut in 2 halves and removed in toto. And then the remnants of the bag and what the material encountered was removed with the help of the cutter. Okay, in this particular case, this is the last case, this patient had very good vision as compared to the other two. On presentation, she was 636, but this is what we encountered on vitrectomy. Inferiorly necrotic patches and severe retinitis. It was almost encroaching the macula, as you can see in the video. So while we are doing the complete vitrectomy, this is the kind of the breaks we have been facing. She was very lucky that she didn't develop any retinal detachment here. Okay, on magnification, we saw that this was the membrane covering the macula, which was removed with the help of the forceps. So here we have to remove this part of the posterior hyaloid because this is sequestrating all the bacterial toxin and the colonies. So you can really appreciate how much the macula has been saved. So this is after 6 months when we removed the silicone oil because there are chances of retinal detachment. So all those patches were fibrosed and the retina is still attached, and this lady has a vision of 612 post-operatively after the removal of silicone oil. So again, early detection and early removal and complete removal is the key to treat with the endophthalmitis. Thank you.
So next speaker, if he's here, Amir Arin.
Bismillah ar-Rahman ar-Rahim. I'm Dr. Amir from Armed Force Institute of Ophthalmology, where I'm consultant via surgeon, and I'll be presenting my work on outcomes of early vitrectomy in post-surgical and post-traumatic endophthalmitis with intraocular foreign bodies. As we all know that endophthalmitis is a severe purulent intraocular infection and accounts for 0.07 to 0.1% after cataract surgery. This is the endophthalmitis vitrectomy study group, results of 1995. And what's the rationale of vitrectomy? Decrease inflammatory debris, decrease microorganisms, decrease macular toxicity, And this is the rationale of early vitrectomy prevents the complication of infective load and improves the final visual outcome. And this is the complete and early vitrectomy study CEVE presented by Kuhn in 2005. So we follow his guidelines in management of post-operative endophthalmitis. And why to perform complete vitrectomy? So in endophthalmitis vitrectomy study said that if there is no PVD, no aggressive efforts to induce PVD should be done. But by detaching posterior hyaloid, surgeon gets the chance to bare retinal surface, allowing complete removal of debris and pus. So however, complete vitrectomy will lead to posterior vitreous cortex only and not in the periphery, where surgeon must be conservative. So PVD should be induced in the posterior part only, not in the periphery. And this is the study I have been posted from a combined military hospital, Peshawar, to FIO. And this is my 2-year data in which we have included all the cases of acute post-op endophthalmitis and post-traumatic endophthalmitis with and without intraocular foreign bodies. And it is pertinent to mention that these post-traumatic endophthalmitis are because of the blast injuries, bomb blast injuries, which had intraocular foreign bodies, and they led into post-traumatic endophthalmitis. We excluded those who could not do a complete 1-month follow-up, and or those patients which have severe corneal edema obscuring the view. So this is the Kuhn's criteria which he has mentioned in his studies, that if you see a good fundus, you can go for the medical treatment, but if the medical treatment, if the patient improves, you can continue with that, but if he doesn't, so you go for the vitrectomy. In my cases, the patient didn't have a good view, so I went for vitrectomy. Now, this is an important thing while you are managing the patients who are having bomb blast injuries or improvised explosive device injuries. So what I do is I use ocular trauma score, and I make the score based on these findings. This ocular trauma score, it does not inculcate intraocular foreign bodies, but without that, whatever the score is, this is what I sit with my patient before I do the surgery, and I consult them about the probability of vision he's going to get. So most of the patient, they are in the OTS score 1 or 2, and generally with all those patients which are having intraocular foreign bodies, they generally go in score 1. So I always tell them that there is 73% chance that they are going to land in NPL vision, and 27% chance that they are going to have some vision. So this is very important medical legally. We all must use these trauma scores for the consent and counseling before the surgery. So these are the results. A total of 30 patients, 20 were post-surgical, and 10 were post-traumatic, and 8 were having intraocular foreign bodies. So at the end, you can see that initial visual acuity was less than 660 in all patients, but final visual acuity was greater than 612 in 19 patients, 612 to 660 in 8 patients, and less than 660 in 3 patients. And this study is comparable with the international studies done. And now I'm going to go for certain surgical tips that I have learned in my experience. I am the one who do not use silicone oil in all my cases of endophthalmitis, and I do not do a 360-degree laser. So I'll tell you what is my trick and how I'm doing it. So generally I use local anesthesia, and I go step by step from cornea to macula. I keep blood, chocolate, and Savorod agar at hand before surgery. I do not turn the infusion until I get a clearer view. I use an AC maintainer if there is a poor view and I cannot see the infusion cannula. Then in some cases I may have to remove the corneal epithelium. I do an AC wash. Removal of membrane is being done by the forceps, the endoforceps. All these membrane which there are different methods, but I use them. I use the forceps. Then I do a posterior capsulotomy and I flush the bag to clean it. Then I go for the core vitrectomy and I try to induce PVD. And in the vitreous, I go In the clear vitreous, in RD cases, we go from posterior to anterior. But in these cases, we go from anterior to posterior, because white vitreous layers with streaks of hemorrhage, it just looks like a necrotic retina without peripheral blood, patent blood vessels. So I dig a vertical well nasally, and because if there is a break, it would be on the nasal side. Then in the periphery, I do not go for a PVD, I just trim. And whenever there is a necrotic retina, I do not induce PVD over it. Then if there is an iatrogenic break, I do a laser retinopexy and put oil. And then I do passive vacuuming with silicone tip fluid over the macula to remove all the macular hypopyon. And intravitreal antibiotics I give at the end of the surgery while I have done a fluid air exchange. I put 1 milligram vancomycin and 2 milligram of Fortum, ceftazidime. So that I do at the end after I've done fluid air exchange. And if I have to put silicone oil, I use half dose of antibiotics of these. And I inject the antibiotics before I inject the silicone oil, and I tell the patient not to lie supine, but to change his posture every 1 hour so that the antibiotics goes all over the retina. And I place sutures in the end, especially when silicone oils are used, and give oral antibiotics, topical steroids too early. Now, in cases of endophthalmitis retinopathy, I always use silicone oil. And what is endophthalmitis retinopathy? Peripheral uveitis. If I see a peripheral uveitis, pale, coarse, ischemic retina with sclerosed vessels in the periphery, retinal hemorrhages, yellowish white spherical colonies in the inferior retina. So these are the cases where I put silicone oil. And especially if there is macular endophthalmitis maculopathy, and there are posterior pole hemorrhages, exudate, ischemic looking macula, or macular hypopyon. So in macular hypopyon, I go for the flushing with the fluid needle. The advantages of silicone oil is that bacteria do not multiply in silicone oil, and it prevents and treats the retinal detachment and gives a clearer view. And when do I inject? When there is a break, and if I'm not sure whether I've created a break or not, so I'll go for silicone oil. If RD is present, I will give, and if there is ischemic endophthalmitis retinopathy or maculopathy, I inject. And when not to inject, if the vitreous is not adequately removed, I will not inject silicone oil unnecessarily, because the pathogens will be trapped in the area and it will cause localized toxicity and further retinal necrosis. So that's the danger. Now, few of the surgical tips for intraocular foreign bodies. My first thing is that never order an MRI, always order a CT scan. Number 2 is always go for a 3-dimension size of the intraocular foreign body. Radiologists often give 2-dimensional size, like 6 mm by 4 mm. So once you are dealing with those foreign bodies, you have to take them out as a 3D structure, not as a 2D structure, because and then their heavy intraocular foreign bodies cannot be brought up by PFCL. Especially if there is a case of a bomb blast injury, the metal which is used in those bombs, they are very heavy, you cannot take them out by the help of PFCL. Then this is something I've learned after very hard experiences, that always measure the tip of your instrument with the caliper before you go in. So if there is a foreign body of 3 mm, those instruments which we use through a 23 gauge system, the maximum size, the mouth of those forceps, they open by 2 mm only. So you cannot take a foreign body which is 3 mm size by those forceps. So what you have to do is take a 3-dimension scan, 3 mm by 4 mm by 6 mm. That is the 4 mm by 4 mm by 6 mm is the maximum size of foreign body that I have removed from the eye. A case of bomb blast injury. So measuring the size, then measuring the size of your instrument tip, that how much it can open. Only then, and if you have the available instrument size, only then please enter into the eye. Otherwise don't, because you will be stuck then. And it will never ever come up. And secondly, once you have done the vitrectomy, previously it was trapped in vitreous or somewhere and it was not moving. But once you have cleared the vitreous, now it is roaming around and it is causing the breaks. So it will be, hell if exactly at that point you got to know that the instrument tip is not opening that much. So you have to arrange the instrument which is better. So, and then if the size of the forceps is equal to or less than the size, it will never engage. Then IOP, intraocular foreign bodies, they do not forgive. Because if you think that I can do it on the table, you won't. And while calculating the size of intraocular foreign body, you should add the length of the two sides of the intraocular foreign body and add the size of the forceps. And then additional 1 mm to calculate the size of the incision you need to take through foreign body out. So many a times, if the size of the foreign body, for example, comes up with this calculation, more than 5 mm, with this formula, you have to go for a limbal incision because that much bigger scleral incision you can't make. Then in blast injuries, always remember the foreign bodies are more than one. They can be multiple. And in many cases, you may have to do a clear lens extraction for removal intraocular foreign bodies. So you have to keep a 3-piece lens beforehand for placement at the end. And then always keep Denseron, heavy liquid PFCl beforehand for a vitrectomy. And for timing of vitrectomy, I would say that earlier the better is a good option because if you go late, you will encounter more PVR in such cases. And last thing is never compromise on visibility. Do not go if the visibility is poor because you can do more damage than benefit. In the conclusion, I would say that vitrectomy is the only solution for endophthalmitis for complete visual rehabilitation, and giving early intravitreal injections and coordinate with VIA surgeon for those who are referring for further management by the VIA surgeon. Thank you very much.
Thank you, Dr. Arain. Next speaker, Kitaliza and Dayani, please take the podium. I'm sorry we have to rush a bit, but we're half an hour late and we still have 3 speakers and they need the room for the next session. Please.
Thank you, Professor Jeannie, and I hope you're still eager to hear my presentation. So I'm going to talk about causes and management of idiopathic peripheral vasculopathy or Eales disease. I have no financial disclosure. So this disease is first described by Henry Eales in 1880, and it's an idiopathic occlusive perivasculitis at the peripheral retina, or sometimes termed periphlebitis, with 3 distinct features or characteristic features, which are retinal non-perfusion, neovascularization, and also recurrent vitreous hemorrhage. It's found in UK, US, and Canada until early 20th century, but recently more predominant in India, Pakistan, and Afghanistan, and also in my country. And somehow many of the cases we see come from East Indonesia, especially West Papua. So the pathophysiology of Eales disease is still debatable. Many would argue it's an inflammatory vascular obstruction, first related to Mycobacterium tuberculosis, which is hypersensitivity to the non-viable of DNA of the DNA of the tuberculosis bacilli, and also may be related to human leukocyte antigen, retinal autoimmunity, free radical mediated damage, or hyperhomocystinemia. And these are the 3 distinctive features of Eales disease. I think you are all quite familiar with it. So this is retinal phlebitis, and then peripheral non-perfusion, and also retinal neovascularization as shown in the angiogram. And the diagnosis is, of course, clinical signs and symptoms, including floaters, sometimes sudden blur vision if the bleeding is massive, and then of course blur vision. And imaging is important. We sometimes employ fluorescein angiography, B-scan ultrasound, and also OCT. And of course, we must rule out other causes of neovascularization, especially diabetic retinopathy. And for laboratory workup, I think it's almost routinely done in our center is to do a IGRA test, an interferon gamma release assay. And for the management, it includes medical treatment, including corticosteroids, anti-tuberculosis treatment, cyclosporin and azathioprine, and also if hyperhomocystinemia is found, then treat with folate and also vitamin B12, and also antioxidant supplementation. Vitreal anti-VEGF sometimes could be given in cases of macular edema and also to prevent the progression of neovascularization, also laser photocoagulation, and also pars plana vitrectomy, especially for non-clearing vitreous hemorrhage and also tractional retinal detachment. And also periodic monitoring is also important. And the prognosis, blindness is usually due to retinal detachment and neovascular glaucoma. I think recently I had a case with bilateral neovascular glaucoma suspected due to Ehlers disease. And visual improvement is favorable in cases with fewer episodes and shorter duration of vitreous hemorrhage. And photocoagulation before vitrectomy yields better prognosis. And I'd like to share you one case. This is a male 53-year-old architect. He had right eye blur vision since 4 months with left eye floaters as well. And his initial best corrected visual acuity of the right eye is hand movement and normal on the fellow eye. We diagnosed him with right eye vitreous hemorrhage, left eye peripheral retinal vasculitis suspected due to Ehlers disease. We did a workup including IGRA test and consultations to internal medicine. We did PRP laser on the left eye, and then we did a pars plana vitrectomy with endolaser. Hopefully the video works. Okay, so this is quite a straightforward surgery. We see the vitreous hemorrhage, quite dense. Then we did a pars plana vitrectomy, first core vitrectomy, and then more to the peripheral side. And then we can see that the condition of the underlying retina where there's retinal hemorrhages as well as vasculitis. And then we did a fluid air exchange and then followed with laser PRP. And I just put air at the end of surgery. So this is the condition 1 month after surgery of the right eye, and also the other eye has undergone laser. Almost full field, and the eye looks quite quiet, stable. But then again, after 1 month, the right eye experienced cystoid macular edema or CME, and also the left eye follows suit. Yeah, so there's macular edema as well. So we gave 3 doses of intravitreal bevacizumab. And also, this patient was positive for IGRA, so he also underwent a 9-month treatment regimen with antituberculosis. And also, the right eye developed cataract. He also underwent cataract surgery. And by the end, his vision improved to 6/6 on both eyes. So I think for the discussion, for conclusion, Ehlers disease is a diagnosis of exclusion. It's mainly associated with Mycobacterium tuberculosis. Treatment is tailored to different stages of disease, and many times we have to do multimodal treatment. And then visual improvement may be achieved with medical and laser treatment, and vitrectomy is also essential elements in Ehlers disease treatment. And anti-VEGF may be useful in cases with CME. It's even debatable if we can give it earlier, maybe by the end of the surgery. So I thank you, and hopefully you could join us next year in the APO, which our country is hosting. Thank you very much for your kind attention.
Thank you, Gita Lisa, and thank you for the clear presentation, keeping to the time so strictly. Next speaker, Yasmin Peralta. The podium is yours.
Thank you for the presentation. Thank you to all of you to be here at this time, to stay to the end. I promise that it's a short presentation, but a beautiful and interesting one. Let's talk about bimanual surgery. The objective of the presentation is to show you the importance of using independent light to let us manage other instruments as we need it. Start training the coordination of both hands into the eye. Since we are in a fellowship, there are some complex cases that go better with bimanual technique, and we have the technology, let's use it. Let's see, this is a complex retinopathy case that we have a very hard fibrosis in front of the retina. We try to take it out with the light pipe and the vitrector. And let's change to bimanual technique. We put a chandelier and with the scissor and the forceps try to cut all that hard tissue that is over the retina. You can use the forceps and the vitrector at the same time, or use the cauterio and the aspiration. Just put PFO, do the interchange, and the laser. Here we have another case, is a retinopathy, diabetic retinopathy 2. We try to start with just one hand, do as much as we can, try from the pole to the periphery. But it's a moment to change. And here there are some points, some tips that I wanted to see. That the scissor, it doesn't work just cutting, that we can drag the tissue, with the scissor too. And we can use both instruments independent of the right or the left hand, just in the one that is better to use. And our surgery becomes more clear, more quiet. We can do many things at the same time. Here is another tip. If you notice, we can close the scissor and just open and drag the tissue. Look, notice here, after this. We close the scissor and open it, and the tissue is going to start going out easily. And just do laser now and finish the case. And here is the last case, the last video. This is a phalsemic patient. And we know that these retina are very sticky and very fragile, so we have to be careful in our movement. We try to do the core and take out as much as we can. In that part, we have a retinal detachment already, so we have to be very careful it doesn't get out, and just let it like this, go in another part, and then change to bimanual technique. We can take the tissue with the ILM forceps and try to cut carefully, very near to the retina, without doing any damage to the retina. Very careful doing that, just not try to not make holes because of the pathology, and then finish the case. So take-home measures, some surgeries go better with bimanual technique. Just allow you to try it. I know that all of you can do it. Thank you very much.
So, Yasmin, thank you for the lovely presentation. I just want to make a point. Ophthalmic surgery is not different from general surgery, and we should always remember this. So you showed the concept of blunt dissection of the tissues by entering with closed forceps and opening them. That is very, very good, and I'm glad that you showed it. Also, I think that today there is a tendency, especially for diabetic retinopathy, to think you can solve everything with small gauge, so 25, 27. That is not the case, and you showed that very well. Sometimes, according to the severity of the case that you have, you must use bimanual. And I say that as a concluding remark, God has given you two hands for a reason, and use them both. So thank you very much. Any questions before we close this session? Then can we just say thank you for staying late, thank you for being here, and thank you for all the speakers for their patience. Thank you.
Lastly, we invite all the speakers to take a photo. Yes, please. Dr. Nikolov, take a photo.